pharmacodynamics describes the action of drugs on the body, and the drugs work through receptors. The drugs work through receptors to prompt some cellular activities. Once the drugs bind to the receptors, they engage in what we call signal transduction, because the drug or whatever the ligand has come with a signal, and once they combine together, they transduce it so that now the cell can act on it. So we are saying the drugs act as signals. Receptors are detectors of the signal. Now, if a drug binds on a receptor and the effect that follows is such that it mimics the natural effects of that receptor, then the drug is an agonist. The drug is an agonist. Now, we know that the receptor ligand, and in this case, receptor drug complexes, work through what we call second messenger systems. And there are a number of them, which I know you have already worked through. Maybe just to confirm, any second messenger systems that you are aware of, just a listing, no explanations. Second messenger systems.
Cyclic AMP.
Right, cyclic AMP, CAMP, another.
AP3.
AP3. Okay.
Calcium ions.
Yes. The calcium calmodulin system, another. Okay. So that the assumption is that those ones are with you, and that is all right. The second messengers play an important role as effector molecules in the signal transduction cascade. We call it a cascade because one signal leads to another action and another action and another action until you have the ultimate action. The drug receptor complex cells have many types of receptors, each specific to a particular agonist. Each receptor agonist interaction produces a unique cellular response. Example, the cardiac cell membranes contain beta-adrenergic receptors for binding epinephrine or norepinephrine, and muscarinic receptors for binding acetylcholine. While we are there, I will ask, what is the effect of sympathetic stimulation on the heart? What is the effect of sympathetic stimulation on the heart? Clinton?
The sympathetic stimulation increases heart rate.
Great. How about the force of the heartbeat?
The force will also increase.
So it is actually inotropic as it is chronotropic. And that is what now Lavi is saying, fight or flight response. That is a mental state that you feel frightened or you feel the urge to protect yourself. Now, what are the chemicals that mediate this increase in heart rate in the context of sympathetic nervous stimulation? It is adrenaline. Therefore, adrenaline increases the heart rate. It also increases the force with which the heart beats. This adrenaline is a neurotransmitter just as it is a hormone. When it reaches the heart, it binds to beta adrenergic receptors. And that activation will lead to increase in heart rate. In fact, we have a drug called adrenaline, which we use in emergency resuscitation if somebody is collapsing and the heart rate is too low. We will actually inject adrenaline to increase the heart rate so that it can pump a little more faster and support the tissues that are lacking oxygen. How about the sympathetic activity in the airway? What is the effect of sympathetic activity on the airway? Hello? Does it open the airway or it constricts the airway? Now, the reverse is true actually. Sympathetic activity opens the airway. So sympathetic stimulation will make somebody's airway more patent. And therefore, when you give a drug like adrenaline, it must depend on what you want to achieve. We can use the same drug in asthma, which is a disease that narrows the airway. We will use adrenaline to open the airway. But when we are giving it for the purpose of the heart, we'll be trying to make the heart pump a bit faster. So the receptors count the type of receptors and the kind of actions that follow. When we look at sympathetic activity on the GIT, it will reduce digestion. Let's look at now acetylcholine effects. Acetylcholine effects on the heart. Does it increase the heart rate or reduce the heart rate? Acetylcholine will reduce the heart rate. How about acetylcholine on the respiratory tree? Constrict or open? It will actually constrict. And so some of the drugs that we use even in asthma are actually anticholinergics. Good. So let's look at that which I had given here as an example. Beta-adrenergic receptors, they bind to epinephrine or norepinephrine, and that will increase the heart rate. Muscarinic receptors, they bind to acetylcholine. We know that will reduce the heart rate. These receptor types interact dynamically to regulate heart function. The magnitude of cellular response is proportional. That is a critical point there. Is proportional to the number of drug receptor complexes formed. This concept is similar to enzyme substrate interactions. If there's saturation in terms of enzyme substrate, then we expect a maximal response. Equally, in the drug receptor complex, if the binding is strong, then we expect a more magnified response or magnified effect. But we are noting here a nota bene there that not all drugs work through receptors. Not all drugs work through receptors. Some drugs just have some chemical reaction as their way of exerting the influence. For example, acids, they are given to neutralize gastric acid. When you take a drug like Acto, an antacid, the job is to neutralize the gastric acid. An antacid, for example, this will be a base. When you given the mix with the gastric acid, then we'll have the acid will be neutralized. So that was just to note. Receptors exist in two forms, active and inactive ones, and they're in reversible equilibrium in such a way that receptors can shift from being active to inactive or inactive to active. What is the purpose of agonists? Agonists tend to shift the equilibrium towards active. So they activate the receptors so that the natural effects are mimicked through the effect of the drug. Antagonists, on the other hand, they stabilize the inactive state. So the activity is not excited. Partial agonists, they do the same thing as agonists, but the magnitude of it is less. The fraction of receptors that are activated are less than those that are activated by a full agonist. We have receptors which may include enzymes, nucleic acids, or structural proteins. That's in terms of their form. These receptors are classified into four major families. And the families there, those are the ones you spoke about in your assignments. We have the ligand-gated ion channels, G protein coupled receptors, enzyme linked receptors, and intracellular receptors. We are noting that hydrophilic ligands, they bind to cell surface receptors, families 1 to 3, and hydrophobic ligands diffuse through the lipid bilayer and bind to intracellular receptors, family 4. Hello, are we there?
Yeah, we are there.
So why are we saying family 1 to 3? Family 1 to 3, the ligands bind on the cell surface. And family 4, the ligands go through into the cell. Let's look at the ligands again. I mean the cell families. 1 ligand gated, 2 G protein, 3 enzyme linked. Those are family 1 to 3. Then the fourth are the intracellular receptors, family 4. Okay. How does it happen that in family 4, it's intracellular? Which kind of ligands are the ones that would work through family 4, the intracellular receptors? The qualities of such ligands. Sorry, Victor, would you like to speak? Kindly go ahead.
The ligand for it will compose of the lipophilic that will cross the cell membrane.
Very well. Now, from the kind of things like hormones, which hormones are likely to cross the cell membrane?
The steroidal hormones.
Okay. Examples?
Like uh, tes- testosterone.
Okay. Generally, the sex hormones are generally steroidal in nature, so they will actually cross the cell membrane. Good. So those are just that's a screenshot I did. from a textbook. Ligand-gated ion channels, you see how it comes. This one will give us action potentials. These ones will lead to protein phosphorylation equally to the enzyme linked and to the intracellular. But the mechanisms of each are the ones that will give us a difference in terms of which second messenger system is being used. Which second messenger system is being used. You see the one for the G-coupled, which second messenger system is being used? Is that one visible? Hello? Is it readable, Ama? That is too faint. Lavender, are you able to see that screen?
Yes.
So for the G-coupled proteins, the G protein coupled, CAMP, and ionic calcium. How about for the... Okay, I think I've done all the summaries there, so I don't need to waste a lot of time there on things that you have already looked at. I'm looking for something to explain. That is the one I was looking for. Transmembrane ligand-gated channels. Let's read through that one. So someone to read.
Ligand-gated ion channels have a drug binding site on their extracellular portion T.
This
He
hiyo
said,
imepotea kidogo hapo, iliachana. Yeah, this site.
okay. This site regulates the opening of the ion channel pore across cell membranes. The channel remains closed until activated by an agonist. Upon activation, the channel opens briefly in milliseconds. Function depends on the type of ion conducted through the channel. These receptor-mediated functions like neurotransmission and muscle construction. Example, nicotinic receptor activated by acetylcholine opens channel allowing sodium influx and potassium outflux, causes action potential in neurons and contraction in skeletal and cardiac muscles.
Yeah, this is what we use. This is actually the most predominant in many cells, but it's not only the sodium and potassium. There are other ways that are actually also useful. Next, that is the other one that I wanted us to look at. Just read through that.
Example 2.
Okay, just say GABA receptors.
Yes, GABA receptor activated by GABA increases chloride influx, leads to hyperpolarization of neurons, reduces the chances of generating an action potential. Drug binding site also exists on voltage-gated ion channels. Example, local anesthetics bind to voltage-gated sodium channels, inhibit sodium influx, and decreases neural conduction.
So those three are the ones I wanted to make some little input there. When we there's binding to GABA subunit A subreceptor by the GABA We know GABA in full is gamma aminobutyric acid. It's actually a form of a neurotransmitter. We have seen that it increases chloride influx. Unlike the conventional way where we have known that binding of the neurotransmitter increases sodium influx and potassium efflux. Now, the difference in these cases, we are having hyperpolarization of neurons, and therefore the chances of an action potential are reduced. Whereas when we are looking at the nicotinic receptors, when we have an influx of sodium and efflux of potassium, an action potential is generated. So what effect will it be if we are doing GABA reception or GABA effects, for example, on the skeletal muscle? What will be the difference in the skeletal muscle between GABA excitation and nicotinic excitation? What will be the difference between GABA excitation and nicotinic excitation? Hello? In other words, what is the effect of acetylcholine, which works through nicotine receptors on the skeletal muscles, and what will be the effect of GABA, which works through the GABA receptors on on the skeletal muscles? Okay, what happens when acetylcholine works on the skeletal muscles? Precious.
Yes.
What happens for when acetylcholine works on the skeletal muscles?
There is contraction.
Good.
Contraction of muscles.
Yes. And when they contract, they will end up relaxing, isn't it? So actually, it's the nicotinic receptors that enable us to move, like muscle contraction and relaxation. When the actin myosin filaments must cross-link through the contraction process, that is excited by nicotinic receptors. But what happens when GABA comes in? When GABA comes in, instead of working through the sodium potassium exchange, we are now working with what? Chloride. And chloride, we have seen that it is going to cause hyperpolarization of the cell. An action potential will not be generated. If there's no action potential, will there be contraction? There will be no contraction. That is why when you're going to look at the CNS pharmacology, you're going to look at such a drugs like diazepam ama Valium. Labda mtu amewahi zimeza kidogo kujaribu kupumzika, kulala usingizi mzuri, but we give it to do muscle relaxation. When we give it, the skeletal muscles relax. When you give somebody diazepam, the skeletal muscles relax, because diazepam works on GABA receptors. Fortunately or unfortunately, the same diazepam has many other benefits, as we are going to look at it. For people who have involuntary contractions from alcohol withdrawal, yeah, morning after mess of a lot of imbibing, we'll still give diazepam, and you'll find them calm down and feel very relaxed. Okay, but we can also poison somebody by causing a hyperpolarized state using other chemicals, which we are going to see. Very well. How about the third part of local anesthetics bind to voltage-gated sodium channels? They inhibit sodium influx and decrease neuronal conduction. That's another very important application. We have drugs that work like that. A drug like lidocaine, we give it locally, it blocks neuronal conduction, and with that, we can stitch somebody without them feeling pain at a local level. Okay, so we are going to go into those things in due course. Enzyme-linked receptors, those ones you will read. General statements there that agonists mimic the action of endogenous ligands at receptors. Magnitude of drug effect depends on receptor sensitivity to the drug and drug concentration at the receptor site. Drug concentration at receptor site depends on dose administered, pharmacokinetic factors. Those ones are general statements that we have already gone through. Graded dose response relationship. Someone to read that?
Graded dose relationship. As drug concentration increases, pharmacologic effect gradually increases. Maximum effect occurs when all receptors are occupied. Plotting response magnitude against increasing drug doses produces a graded dose response curve. Two important characteristics from this curve: potency, efficacy.
Okay. Graded dose response relationship. As drug concentration increases, pharmacologic effect gradually increases until all the receptors are occupied. It's just like an enzyme reaction. Once all the sites are saturated, there'll be no more further change in the rate of the metabolic actions. Two important characteristics, potency and efficacy. What's the difference between these two? Potency, the amount of drug needed to produce an effect. I remember sometimes guys used to make a joke in terms of when men and women are out there for a drink. Is a bad example, but let me use it. Kulikuwanga na Guinness kubwa na Guinness ndogo. And people used to joke and say Guinness ndogo is more potent. Why? Because inashika haraka. Sijui kama ni ukweli. Mko na experience? Nurses Club wameshangilia. Hati hiyo ndogo at is more potent. So somebody will go and say nataka ile ndogo, sio kubwa. How they knew that it's more potent, I don't know. Mika has given up. Haya, using'ang'ane sana mahali uwezani, kubali. So you're saying potency is the amount of a drug needed to produce an effect, determined by concentration for 50% of the maximum effect. So if we can use a very small drug to get 50% of its effect, then that drug is more potent. And I've given examples there of some antihypertensives. Candesartan, which can be given between 4 to 32 milligrams, is more potent than irbesartan. You see, in this case, we can use only 4 milligrams to get the effect, but whereas in this other case, we might need to use 75. There are certain drugs that are even more potent. A drug like digoxin, you use the amounts in terms of decimals, they are fractions of a milligram. Efficacy, the magnitude of response when the drug binds the receptor. This depends on the drug itself and the number of receptor drug complexes. And in that case, to go back to what we have already spoken about in terms of the full agonists, which will activate all the receptors. The partial agonists, which will activate the receptors but to an extent, not fully, or the inhibitors. And you have said there that efficacy is more clinically useful than potency. The greater the efficacy, the better the therapeutic effects. So that's a take-home message. Receptor binding equation, that one I'll give it to you to read. Okay, these ones are important. I think let's just read through them because back to kidogo. Somebody to read through that receptor binding equation.
Relationship follows the laws of mass action. Formula: fraction of receptor bound is equal to the d over d plus that. D is equal to concentration of free drug. Kd is equal to equilibrium dissociation constant. When D is equal to Kd, which is 50% of receptors are bound. Lower Kd, higher drug receptor affinity. This is useful for modeling drug receptor interactions. Next.
Okay, that one you'll interact with it. Let's go to the next slide. Read that one.
Law of mass action applies if assumptions are met. Number one, response is direct. Infinite. Okay.
Directly proportional.
Yeah. Response is directly proportional to the number of receptors occupied by drug. The second assumption is that the Emax occurs when all receptors are bound. The third assumption be one drug molecule binds to one receptor molecule.
Okay.
Mathematical expression E is equal to the Emax times D over D plus KD, where E is the effect of the drug at concentration, D and Emax is the maximal effect of the drug. Drug affinity for receptor is related to its potency. Drug may bind to multiple receptor types, which is the therapeutic plus adverse effects. Receptor affinity versus drug potency curves help to establish specificity and selectivity.
Okay, these again are general statements, but key are the first 3 points. Response is directly related to the number of receptors occupied by the drug. We have just seen this. Emax being the maximal effect of the drug, is achieved when all the receptors are bound. And we have just again been reminded that a drug molecule can bind to more than one drug. I mean, one drug molecule binds to one receptor molecule. Those are the assumptions in the law of mass action. So in this case, I would ask, if we increase the dose of a drug, what happens to the Emax? What happens to Emax when you increase the dose of the drug? Hello?
In my opinion, I think the Emax, the maximal effect of the drug also increases when the dose is increased.
Yes, it increases, but not indefinitely. It increases until all the receptors are occupied. When all the receptors are occupied, however much you increase the dose of the drug, it will not change a thing. And that is why drugs have dosage forms and the amounts that have been put up as a limit. We will, for example, say we want to give a drug like Panadol, and we are saying give 1 gram. The question is, why not give 5 grams? You still achieve the same pain relief as 1 gram. So the additional 4 grams will be useless because the 1 gram was sufficient to for example, bind all the receptors. I think now we've gotten the point of why we do not arbitrarily just increase the dosage of drugs. We give the dosage of drugs up to what we consider the most potent levels. And at that stage, science or research has shown that all the receptors that the drug works through will have been saturated. So even if you add the drug, it will be a useless molecule there. It has nothing to interact with. That's the point I wanted to make. The rest of the things, I think I can give you to read by yourselves. Hapo sawa? Ama tupitie hapo kwanza tumalize. There are only 5 slides.
Okay, we can just
Tusome mwisho tuone a few things that I can explain.
from there.
Yeah.
If a specific receptor population is essential for a physiologic effect, the affinity of an agonist for those receptors is directly related to its potency. Higher receptor affinity, which results into greater drug potency in producing the desired effect. Many drugs and neurotransmitters can bind to multiple receptor types. This can lead to both therapeutic effects and adverse effects. To understand drug selectivity and action, correlation curves are constructed to relate receptor affinity and drug potency for specific receptor subtypes.
That one, somebody had read through that, isn't it?
Yeah.
Yes.
Okay. Then from there, I said those ones are just general classifications of what is already up there. That one, we looked through, isn't it?
We were here.
We were here. And I said these are just general statements where we say agonists bind to receptors and produce biologic responses. What influences that? I don't think I need to read through things we have already spoken so much about. Full agonists, I showed that up, that they bind receptors and produce maximal biological response like endogenous ligand. See, that one we have already said. Hello?
Yes.
Yeah, so that one, the rest are just general clarifications. But the most important point there is that a full agonist, once it binds the receptor, it produces maximal biological response like the endogenous ligand. In other words, like when you're talking about something like adrenaline, when we give a drug like phenylephrine, it mimics norepinephrine almost exactly. So the effects of a norepinephrine, we will actually see them when we give phenylephrine, is a full agonist. So the activation, we don't need to go, I will not go into that. The next was partial agonist, have intrinsic activity between 0 and 1. In other words, they are a fraction of the full agonist. They will not give us their effect equivalent to that of a full agonist. They will not give us the effect that exactly or almost perfectly mimics that of the endogenous ligand. But they will give that effect to an extent, to a percentage. So just that is what we can say. And then we can go to bullet number 5. Increasing receptor occupancy by partial agonist reduces effect of full agonist, lowering Emax toward partial agonist's level. So to some extent, a partial agonist might actually reduce the effects of a full agonist. Therapeutic use, example, this is drug aripiprazole. This is a real drug that we have given to patients who are what quote unquote we call mad. Okay, to confirm, am I still being heard?
Yeah.
Okay. Okay, that is okay. So like that drug is a good one, but it doesn't have the very bad effects of other drugs that help in managing madness, as we are going to see. How? All those drugs that help managing schizophrenia or psychosis, they inhibit dopaminergic pathways. But we are seeing this partial agonist here inhibiting the overactive ones, but then to a small way, stimulating some unactive dopamine pathways. So in effect, the dopamine effects don't disappear completely. Some pathways are inhibited, some pathways are stimulated, the less active ones. And that is why we will have the drug managing the schizophrenia or the psychosis, but without a lot of side effects that are characteristic of the other drugs. So those are the things we are going to look at in due course. Antagonists, they bind receptors with high affinity. They decrease or they block the effects of the agonist when present. They can block agonist binding to receptor, or they can prevent the receptor activation by the agonist. Either way, they are guarding the agonist. This one cannot activate it, or it cannot even bind to it. Competitive antagonists. Let's read that. Competitive antagonists. Somebody to read that.
Competitive antagonists, they bind reversely to the same receptor site as the agonists. Prevent agonist binding, keeping receptor inactive. Example is the terazosin, which competes with norepinephrine at alpha-1 adrenoceptors. Leads to decreased vascular smooth muscle tone and lowers blood pressure. Increasing agonist concentration can overcome antagonist effect. It causes rightward shift in agonist dose response curve. That is increased what? Okay. It does not change maximum effect, the Emax.
Is all right. So what we are saying about competitive antagonists, ni ile unasema mtu amekalia kiti yako. They bind reversibly to the same receptor site as the agonist. So where the agonist works, this one comes and lodges there and blocks the agonist from doing its job. And once they bind there, they keep the receptor inactive, because what they are doing, they are not going to activate the receptor. They are going to keep it inactive. So when the agonist comes, it has nothing to activate. The area is blocked. Okay, we know that epinephrine can contribute to increased blood pressure. When we want to lower it, we want to reduce the effect of epinephrine. And that is why drugs like the terazosin are important, alpha-1 adrenoceptors. I mean, they block the effect of norepinephrine at alpha-1 adrenoceptors. Okay, but we have noted that the agonist, when given in high amounts, it can actually overwhelm the antagonist and exert its effect. Ni kama unaita majeshi, unasema sasa wao watu wamekuja kukalia mahali yetu, hebu watoe. Unaita team. Okay. Then allosteric and functional antagonists. What are allosteric antagonists? They bind to a different site than the agonist, allosteric site. In this case, unlike the competitive agonist, which we saw binding to the site where the agonist binds, allosteric antagonists, they're antagonizing the effects, but they are binding at a different site. They prevent receptor activation without changing the maximum concentration in 50% of the population. They also decrease the maximum effect or the Emax of the agonist. Okay. Example, picrotoxin blocks chloride channel inside the GABA receptor. We remember we said that GABA opens up the chloride channels and leading to hyperpolarization of the cell. To block the GABA, we can give picrotoxin, but which will block the chloride channels inside. Okay. Then functional antagonists. These ones work at a different sites, but they produce different opposite effects. They produce opposite effects. Example, epinephrine relaxes bronchosmooth muscle. Now, when you look at epinephrine on the bronchosmooth muscle, that is sympathetic stimulation. It opens the airway. But what are the effects of histamine? Like when you are having an allergic reaction or an asthmatic attack, the airways block. And epinephrine is very good. In fact, as we speak, like I'm in the hospital now, on a daily basis, we are actually giving nebulizations, especially to children, using epinephrine. Or people with the drug reactions, we are nebulizing them using epinephrine to open their airways. But this epinephrine does not directly oppose the histamine. No. It will simply relax the bronchosmooth muscles, and that effect will actually open the airway without competing with the histamine on its receptors. And that's why we say the function has opposed another function. So the function of epinephrine in terms of opening the bronchosmooth muscles has opposed the function of histamine, which is to cause bronchoconstriction. And that's why we call it physiologic antagonism. Are we still together?
Yes.
Okay. Then we have what we call the Quantal dose-response relationship. Relates drug dose to the proportion of patients showing a response. Responses are a quantal. Effect either occurs or does not in an individual. Now, what does that mean? What do we mean by quantal dose response? What do you understand by that sentence? You know, a quantal dose response relationship describes a drug effect which is binary, which is either present or not present. The graph will actually illustrate the relationship between the dose of a drug and the proportion of the effect. The dose of a drug and the proportion of a population that exhibits a specified response. In other words, which dose is able to give us which kind of response in a certain population or in a certain percentage of the population. Quantal dose response relationships are very important in determining efficacy and safety of drugs. In fact, these curves are quite important in terms of drug studies. Usually, we look at the response in 50% of the population. The response in 50% of the population. Then we have the last thing I would like us to look at. They are called a therapeutic index. And that is very key. The rest were general sentences, but this one is very key. Somebody to read therapeutic index. Sorry? Are you able to see the slide?
Yeah, really
Oh, kindly.
Therapeutic index, TI, definition. Ratio of toxic dose to effective dose in 50% of the population. The formula, the toxicity index equal to toxicity dose of 50 divided by the effective dose of 50%, where the toxicity index equal to therapeutic index. TD50, which is the median toxicity dose, equal to the dose of 50% of the population, in brackets, dose causing toxicity. The median effective dose equal to effective dose for 50% of the population, in brackets, dose causing desired effect. The significance measures drug safety. Larger TI equal to wider safety margin between effective and toxic doses.
Okay, let's take it afresh. Therapeutic index, the ratio of toxic dose to effective dose in 50% of the population. You know, we said that the distinction between the benefits of a drug and the adverse consequences sometimes is very narrow. But it actually varies in regard to different drugs. So we are given the formula for therapeutic index as toxic dose for 50% of the population over effective dose for 50% of the population. In other words, what kind of dose can be able to cause adverse effects in 50% of the population? And what kind of dose can give us the desired effects in 50% of the population? When we get that ratio forms the therapeutic index. Now, why not use 100% of the population? It is for practical reasons. Plus, generally, the drug can be toxic to some people and not to others because of we saw the genetic variability. And also the drug can be effective to some people and not others because, again, of the genetic variability and the other factors, for example, the food, the weight, and so forth. So what amount of the drug can cause toxicity in 50% of the population, and what amount of the drug can be effective in 50% of the population? The ratio gives us the therapeutic index and is a measure of the safety of the drug. If the therapeutic index is wider, then that drug has a wider margin of safety. If the therapeutic index is narrower, then the drug has a limited safety profile. What are the clinical usefulness of the therapeutic index? Someone to read through?
Clinical usefulness of therapeutic index. Therapeutics index determined from drug trials and clinical experience. It shows the range of effective doses and toxic doses, sometimes overlap. High therapeutic index desirable for most drugs. Some low therapeutic index drugs used routinely for serious diseases. Risk of adverse effects balance against risk of untreated disease. Example is the warfarin, which has a low therapeutic index. It requires careful monitoring. Penicillin has higher therapeutic index, but safer. It has a wider margin of safety.
Okay, I would give you this question. Which of the following drugs would require that you document the effects every, for example, 15 minutes?
In my
Yeah?
in my own opinion, I think it's the warfarin.
Yes.
For the fact that it has a low therapeutic index, it means that the margin of toxicity is very narrow. So
The safety profile is very narrow.
it's very narrow.
Yes. So which drug would you be more comfortable to give to a client to use at home between the two?
I'll give penicillin. The fact that it has a wider margin of safety.
because even if the client makes mistakes, they might not be as costly
Yes.
as if you are using warfarin. And therefore, if a patient requires either of these drugs, in which case would you require the patient to be admitted?
Ati?
If a patient requires either of these drugs, in which case would you advocate for that patient to be admitted for the sake of this treatment?
Okay, so I'll advise for the warfarin. This is
Yes.
because it requires careful and close monitoring.
Okay. So we get the importance of these concepts in real practice, and these things inform decisions that we make over patients. And that is why whenever you're having a client and, for example, you're discussing about something like an admission, when you are armed with this kind of information, then you are able to talk to the client scientifically that we require to be admitted because this drug you are going to use, its margin of safety is very narrow. There are very likely bad effects, and that's why we require you to be within the ward for very close monitoring. And if something wrong happens, then we know how to respond in terms of an antidote or corrective measures. Then when you're at home and you're on your own, and you might not even tell that the effects that are following are from the drug. We get the difference. There will be many other drugs of that nature. We have a drug like digoxin that we use in patients who are having heart failure. That drug is given in the dosage of fractions of a milligram. You alter it with just a very limited fraction, and you cause very, very serious effects. So you want to give it only when you can be able to monitor the side effects within your power. But if somebody is outside the facility, then it becomes a problem. And these are things that count even in terms of staffing. When you're having 2-3 patients of this nature in a ward, then you can be sure you have a serious problem in terms of staffing, because then one client can consume a full nurse for a day because of just monitoring for this kind of effect. Otherwise, you can actually lose the client. For example, if this warfarin leads to a lot of bleeding side effects, then you lose the client. Okay. So let's read that explanatory slide as a last one.
Warfarin versus penicillin. Therapeutic index examples. One, warfarin, small therapeutic index. Dose increase results into greater patient response. That is 2 to 3-fold. How do we read that? 2 to 3-fold increase, or 2 to 3-fold INR increase. High doses risk
Just say INR, no problem.
INR increase. Higher doses risk hemorrhage due to anticoagulation. Requires careful dosing. Bioavailability critically affects therapeutic effect. Number 2, penicillin.
So before you proceed, INR is international normalized ratio. International normalized ratio. So you're going to look for it. Okay. So now you can read.
Okay, thank you. Penicillin, safe to exceed minimum effective dose, low risk of adverse effects at higher doses. Bioavailability less critical for therapeutic effect.
Okay. Good. Thank you. We have that was our last slide for the pharmacodynamics. But what are the key messages we are saying? That the drugs, they work like ligands. In other words, they work like messengers. Then they also work through the second messenger systems when they bind with the receptors. So the drug becomes the original messenger, just like a hormone. And at the cellular level, they work like the second messenger systems. We have 4 families of receptors. The ion gated, ligand gated ion channels, the G protein coupled, the enzyme linked, and the intracellular. So the drugs can work through any of those. Those that will work into the intracellular are mostly the lipophilic drugs that can be easily cross the plasma membrane. Either way, be it intracellular or extracellular, when this drug binds with the receptors, they exert a response, a specific response. Now, depending on the way the drugs work, they can mimic the effect of the endogenous ligand, and that will be an agonist. They might mimic, but to a certain extent, that will be a partial agonist. They might antagonize competitively. They might antagonize reversibly. They might antagonize allosterically. They might antagonize functionally. That is how antagonists work. So that is a key. Then when we look at that, we look at the effect of drug dosage in terms of binding the receptors, that when we increase the dose, we go up to a level where the dose, beyond that level, we cannot achieve any different response because the receptors are fully saturated or fully bound. Then when you look at the drug profiles in terms of potency and efficacy, they are quite important, especially efficacy being very important therapeutically. And then lastly, we have looked at the therapeutic index, the ratio of toxicity over effective dose in 50% of the population. In such a way that when a drug has a better therapeutic index, it is much safer. It has more leverage. But when a drug has a narrow therapeutic index, then it is quite prone to very adverse effects, and therefore requires a lot of close monitoring and a lot of precautions. Any question to that end? Okay, Stephen. Kindly, Stephen.
So I would like a clarification.
Yes.
Say that agonists, they provide
Yes.
an effect same to an endogenous stimulus in the body.
Yes.
While antagonists, they provide a reaction or a response that is against an endogenous substance in the body. So let me
Yes.
ask, for example, if we have a drug that is
Yes.
causing a reaction according to the sympathetic nervous system, while
Yes.
against the parasympathetic. So will it be agonist or antagonist?
So the drug is causing.
Like for example, it's increasing heart rate. That one is the sympathetic nervous system,
Yes.
but it's against the parasympathetic nervous system. So will we classify it as antagonist or agonist?
No, okay, you're right. In terms of an agonist, first of all, if the drug increases the heart rate, it is mimicking the sympathetic nervous system. Okay, that is the primary function. Now, what will be its antagonist? An antagonist of it will be a drug that blocks the sympathetic nervous system or promotes a different function, a function that is opposite, even if it works on different if it works on different receptors but blocks. So when we're talking about an agonist or an antagonist, we are looking at that specific drug. For example, when you're talking about epinephrine on the heart, epinephrine is an agonist of a beta adrenergic receptors. Okay, it increases the heart rate. So what will be the antagonist for epinephrine? It will be a drug that blocks the effect of epinephrine. In other words, it blocks sympathetic activity, or functionally, if it promotes parasympathetic activity on the heart. Because either way, the net effect is blocking sympathetic and promoting parasympathetic, the ultimate effect is going to be the reduction of the heart rate. Have I made some communication on that with you?
Yeah, thank you for that. I'm satisfied.
Thank you.
Okay, are you getting me?
Yes, very well.
Okay, I was asking that what is the general value that is considered safe when it comes to the calculation of therapeutic index?
No, every drug has its own variable parameters. Yeah. So we can't just pass one. The profiles really differ between drugs.
Okay.
Okay.
Okay. Nice time.